So is there say there are some interventional radiologists who are at community hospitals where they don't have access to a liquid embolic. Can you still take on embolization procedures in the lymphatic system? Or if you don't have a liquid embolic of some type, it's kind of a non-starter as far as embolization procedures?
No, you absolutely still can. For the central lymphatics, you can really embolize them quite well with coils, provided that you pack your coils tight and you have a fairly long coil pack. So you're not just thinking a couple of coils like you would like in a end vessel, like in the kidney or something. You have to remember that the lymphatics don't have the same degree of clotting factors and platelets that blood does, and coils necessarily depend on that. So in the absence of that, you have to really have more of a mechanical occlusion from what you're putting in there. Now, you're not going to do nodal embolization without a liquid embolic necessarily, because most often, we do nodal glue embolization. Does glue help or onyx help when doing the embolizations? Well, that's how it was originally described, because, the coil is really to create a matrix for the glue to stick to. And then the glue, particularly in some of the more advanced things, when you need it to travel and eliminate multiple weird things, is something there. But can you do an embolization with just coils? You have an extravasating transected duct. You absolutely can. You can also use MVP plugs. You can use amplatzers. All these things in multiple combinations. Just make sure that you lay enough of it down and do a confirmatory injection with non-ionic iodinated contrast. I do that at the end anyway, unless I'm using a liquid embolic, just to show that my coil pack in and of itself has achieved what I want it to do. So I think there's nothing wrong with that at all.
How often do you try and access in the neck to just go a direct stick at the thoracic duct?
I've done that a fair amount.
Okay.
More often than not, it's in the setting of a non-traumatic chylothorax, or something that is going to potentially require a larger platform, whether stent delivery or otherwise. And whether I go retrograde transvenous or direct transcervical, it somewhat depends on the patient and the circumstance. Almost invariably, I still do lymphangiography before. I think there's very little downside to do lymphangiography. It's extremely safe. It may have a potential therapeutic benefit. And you can see it fluoroscopically as it gets up there. And that may aid you in doing a direct access, whether you use ultrasound and fluoro, or ultrasound alone or fluoro alone. It just gives you more options how to visualize your potential target.
Are there ever situations where you found it helpful to get access from below and then work your wire and your catheter up out the egress of the thoracic duct, and then you work your way venous and then floss your way back from the arm to through the neck and then down?
Yeah, absolutely. Okay. I do that very, very routinely. Sometimes actually I have more recently been doing my transvenous access just in the groin. It's already prepped and you don't have to change where you're working from. So I'll do a right groin venous access, go up there, snare my wire and pull myself in. That way I don't have to move around, from, this arm to over here, etc.
Oh, that's slick.
So, you get your wire and you bring it down to the right atrium, snare it, pull yourself down, pull your sheath up, and then take your platform down and around. And, whether it's doing advanced things like IVUS of the thoracic duct, measuring pressures, delivering stents, plasty, whatever, you now have a stable platform. Most patients, a 65 centimeter sheath is going to easily get you there. And then now things within 100 centimeters are easily going to get you down and around most of the thoracic duct as well.
Oh, very slick. All right. So say a BackTable listener is now feeling very inspired by this episode and they want more. And I wish I could say that we had everything. We actually do have some good episodes in this, and we'll link to them in the show notes. But other than having to, learn this over multiple years with multiple sources, do you have any good resources that you can point people, either hey, this is just where you start, this is the ABCs of lymphangiography, or this is a good understanding of the lymph system, whether it's papers, lectures that you've listened to or even given?
Absolutely. At the risk of sounding like I'm plugging myself,
there
was an issue of Seminars of Interventional Radiology, maybe in 2020 or 2021. Though I was the guest editor, but the whole issue was dedicated to lymphatic imaging and intervention. It's 12 different articles written by 9 different authors. So you have a good lay of the land from all around, and it's broken down to lymphatic anatomy and physiology, And then based on, traumatic chylothorax, how to approach that with algorithms, non-traumatic chylothorax, cholecystitis and lymphoceles, hepatic lymphangiography, et cetera. So really covers a lot of it. And, prior to that, one of the gurus, Max Sitkin, had a similar thing in techniques. That was a few years before, maybe 2016, 2017. But really those two things really have a lot of the information, including the setups of how to do it, et cetera.
We'll actually link to both of those references, seminars and techniques. Like whenever they cover an entire topic on something, that can actually be just pure gold. Those are fantastic. And so you were the editor for it. Who were some of the other contributing authors?
Max Itkin and Greg Nadolsky, the group out of Memorial Sloan Kettering with Ernesto Santos, Wally Waleska Pabon Ramos from Duke. I actually had invited, one of the articles was from plastic surgery on the management of lymphedema. I think it's really important to hear, the perspective of our plastics colleagues. What could they do for us? What can they do for these patients? Because almost always, we'll see somebody with leg swelling and we kind of like, I don't know what to do for this patient. And Debbie Rodinovitz discussing pediatrics, Matt Hawkins and Annie Gale discussing lymphatic malformations, et cetera, et cetera. So a good cross-section across the country, domestic and international. Klaus Peipier from Germany talking about different techniques for MR lymphangiography as well. He's a guru in that. So
okay,